Um, Welcome all, and thank you for attending this webinar about sarcopenia, frailty, and cardiovascular disease, organized by the Early and Mid-Career Researchers and Clinicians Committee of the Australian-New Zealand Society for Sarcopenia and Frailty Research, jointly organized with the Cardiac Society of Australia and New Zealand. I would like to begin with the acknowledgement of country. As we gather for this meeting, physically dispersed and virtually constructed, let us take a moment to reflect the meaning of place, and doing so, recognize the various traditional lands on which we do our business today. We acknowledge the elders, past, present, and emerging, of all the land we work and live on, and their ancestral spirits with gratitude and respect. I would hereby like to thank the organizing committee for organizing an exciting event again. Also would like to thank the outgoing EMCR committee members and welcome the new committee members on the team. We are very pleased to have over 290 registrations today, representing 34 countries around the world. As an EMCR committee, our mission is to promote, support, and engage with as many EMCRs as possible to shape the future generation of sarcopenia and frailty research. And this is also reflected in the program today, in which we have 2 EMCR presentations, and all presentations are chaired by EMCRs. Today we have 4 great keynote speakers presenting on their research in sarcopenia, frailty, and cardiovascular disease. Professor Stefan van Heeling, Dr. Aisha Zengin, Associate Professor Caleb Ferguson, and Associate Professor Joshua Lewis. And the chairs will introduce you further. We are very excited to listen to your presentations. Some housekeeping rules before we start. After each presentation, there is time to ask questions. You can ask your question via the raise hand function or via the Q&A features. You can click raise your hand in the webinar controls. We will be notified that you've raised your hand, and if the chair calls upon your name to ask the question, you will be prompted to unmute yourself. You can also type your question in the Q&A feature. The presenters are also instructed to reply to any unanswered questions in the chat after their talk. The webinar will be recorded and made available for those who registered. Hereby, I would like to thank you again for attending this webinar and wish you an inspiring session. I will now hand over to the president of the ANZSSFR, Professor Andrea Meyer.
Thank you so much, Esme, and warm welcome to all of you around the world and around the globe to really join this seminar about sarcopenia, frailty, and cardiovascular disease. And as Esme already said, co-organized by 2 great societies, the Cardiac Society of Australia and New Zealand, and the Australian and New Zealand Society for Sarcopenia and Frailty. And a huge thanks to the EMR committee and the clinicians committee to organize that. I'm at the moment the president of the ANZSSFR, and before, of course, congratulating the organizing team for bringing so many excellent speakers, 4 of them at different career stages, to the table today, I also would like to acknowledge the traditional owners of the lands in which each of us are living and learning and working together, and most importantly, of course, enjoying this seminar today together. And knowledge and experience is dear to my heart. I think that's the key element of the societies we are in, and it's a key success for, of course, future generations. And I pay my respect to the elders, both past and present. Sarcopenia, frailty, and cardiovascular disease are 3 very important clinical conditions. I myself I'm an internal medicine specialist and geriatrician, so I see lots of patients having these 3 conditions, and they are very often co-occurring, and age, chronological age, is the most important risk factor, of course, for all of them. But what we have to learn is that they are co-occurring, these diseases, and that healthcare professionals or researchers in one of the fields like sarcopenia and frailty might not really recognize that they're also in the same individuals, also cardiovascular diseases occur. Whereas healthcare professionals and researchers in the field of cardiovascular disease might not really have heard of maybe frailty, but maybe not of sarcopenia, and doesn't recognize it yet in the field, in the clinical field or in the research. So I think a closer collaboration between our societies, between clinicians and between researchers is very important to increase the quality of life of the individuals we are working with. Therefore, I'm so proud that the societies meet each other here virtually and members, and that we are shaking hands, hopefully, together for a bright future and working even more closely together. So thank you so much, organizing team. You have seen the team, all the names. I won't name them individually, so thanks again. I would like to invite you next to this seminar and to really stay to hear all these brilliant talks, to draw your attention to our ANZSSFR meeting, which we have hybridly in Brisbane, and that's in July 7 to 9. And the topic of our meeting is mechanisms, measurements, and management. So the three M's. And it's really about sarcopenia and frailty, but I am definitely convinced that we will hear about lots of other diseases too, co-occurring in individuals with sarcopenia and frailty. So please look at our website, ANZSSFR annual meeting 2022. If you just put that in on Google, you will find it. And I wish you a very nice symposium today, and stay tuned. And then Ben, I think I have to hand over to.
Thank you, Andrea. So yeah, I'm Dr. Ben Kirk. I'm part of the EMCR committee, and I'll be chairing the first part of this webinar. And I just want to remind all attendees to use the raise hand function to ask questions. That's the first choice, or alternatively, you can use the Q&A in the chat. So Stefan, if you would like to try share your slides now.
So I hope you can see that.
Yep, that's all good. So I'm delighted to introduce our first keynote speaker, Professor Stefan von Heeling, who is a consultant cardiologist and professor of medicine. Prof. von Heeling has authored more than 250 research papers surrounding the pathophysiology and treatment of heart failure, muscle wasting, cachexia, and sarcopenia. And we are delighted to have him today to talk about the role of cardiovascular disease in sarcopenia, frailty, and cachexia. So without further ado, I'll hand it over to you, Stefan.
Well, Ben, thank you so much for inviting me. Unfortunately, no physical presence that is possible at the moment, I guess, but maybe we are lucky and this will take place again. So hello from Germany, hello from Göttingen. I have added into the title cachexia as well, because I believe that there is like a wasting continuum taking place in heart failure and possibly in other cardiovascular illnesses. So I will try my best to give you a bit of an overview. There's some conflicts of interest, what I would like to share with you is some basics about heart failure and obesity, because there's two ends of the spectrum of either losing weight or gaining weight. Cachexia and sarcopenia, can we treat muscle wasting? And finally, about other cardiovascular illnesses, so other than heart failure. But maybe I can start by telling you where the hell is Göttingen? Göttingen is actually, it's a bit like the center of Germany, and it's a very small city, but it has a big university that is more than 200 years old. And we do have a tradition in Göttingen. You see, this is the girl with the goose standing on the market square in Göttingen. And we do have a tradition that whoever finishes his or her dissertation, the MD thesis, PhD thesis, has to go and kiss the girl with the goose. So big university, small city. I'm there for the last 8 years, and I'm working as a consultant cardiologist there, as Ben mentioned. But let's start at the very beginning. Heart failure and obesity. When we talk about heart failure, you may have to acknowledge that there are 3 types of heart failure by now, called HFrEF, HFmrEF, and HFpEF. And when we talk about heart failure, we talk about a clinical syndrome. That means there needs to be symptoms and signs of heart failure, like shortness of breath on exercise, easy fatigue, or possibly also peripheral edema. And the left ventricular ejection fraction defines which type of heart failure is present. So an ejection fraction below 40% is called heart failure with reduced ejection fraction, HFrEF. With an ejection fraction 41 to 49 is called heart failure with mid-range ejection fraction, HFmrEF, and finally a normal ejection fraction above 50% is called HFpEF, heart failure with preserved ejection fraction, that also requires some additional cardiac structure changes. We do have a new guideline by the European Society of Cardiology in place now that calls for introduction of 4 drugs, is a fantastic 4, being introduced into heart failure treatments: a beta blocker, an SGLT2 inhibitor, a mineralocorticoid receptor antagonist, and an ACE inhibitor, or a so-called ARNI, which is an inhibitor of the angiotensin receptor neprilysin system. So this is kind of the basics to understand heart failure, because heart failure is the ultimate cardiovascular disease that has been associated with the development of sarcopenia and also cachexia and frailty. And we are only starting to understand better other cardiovascular illnesses. So looking at the conundrum here, there is no heart failure, a heart failure risk that a little bit everybody of us has, but mostly patients with advanced diabetes, for example, or other cardiovascular illnesses like coronary artery disease. And once heart failure develops, then there is the treatment initiation. And if treatment is initiated with the fantastic 4 that I just mentioned, then there is always a residual heart failure risk. And then we can up-titrate the guideline recommended medical therapy. Sometimes devices such as defibrillators or cardiac resynchronization therapy is indicated. Sometimes we require valve repair and other comorbidity treatment. And finally, patients may decompensate and require hospitalization. And for those patients, there is a worsening heart failure risk. And finally, advanced heart failure may require heart transplantation, circulatory report, or even palliative care. And somewhere in this conundrum, there may be the development of a wasting syndrome. And this is what I would like to talk about for the next few minutes. But there's always some dogmatic views on weight in general in cardiologists and in the general population, because overweight is not considered something good. In heart failure, the situation may be different, because we have understood now, and you can see that in the orange line, that mild obesity is really associated with the best survival in heart failure patients. So a BMI in this publication here already from 2003, and we've seen many database analysis suggesting the same. The best survival is mild obesity, in this case here, a BMI of 28 to 32. Cachectic heart failure, this is the bottom line, here depicted in black, is coming along with the worst survival of all these patients in this sample of 525 patients. So there is two ends of the spectrum of body mass index, the one being cachectic heart failure, the other being obesity. And somewhere the overweight, it seems to be the best in the case of chronic disease, a chronic disease with a poor prognosis, which is heart failure. So mild obesity seems to fare some benefit. There has been a lot of discussion about that, like selection bias. Maybe if there's mild obesity, then doctors are more willing to be more aggressive with their treatment or with their up titration of drugs. So there might be an obesity paradox in being present. However, there has been a lot of debate if this is really the case, and this has finally not been cleared up, but all the database suggest that there is an obesity paradox. Now, looking at cachexia and sarcopenia, I think it is important to understand that cachexia and wasting are always a sign of a poor prognosis, and nature has recently called cachexia in any chronic illness the last illness, because this is usually a sign of a very advanced disease, whether we talk about cancer, about heart failure, about chronic kidney disease. Usually this is a sign of a very advanced stage of the disease. Now, this is the paper that was published by Stefan Anker already in 1997 in The Lancet. And at that time, he studied 170 patients with heart failure. And you can see that those who were cachectic, they had a worse prognosis than those who were not cachectic, with after 18 months, 50% of the cachectic heart failure patients being dead, and 83 of the patients with non-cachectic heart failure still alive. And the prognostic value of cachexia was independent of ejection fraction, New York heart class, age, or exercise capacity. So at that time, Stefan Anker really established cachexia in patients with heart failure, cardiac cachexia, as an independent prognostic sign of survival in heart failure patients. Now, when I was still in Berlin, we looked at muscle structure and sarcopenia in heart failure patients. And we started to understand that patients with heart failure also develop muscle wasting. And muscle wasting develops earlier than cachexia. Now, cachexia is something you only need for the diagnosis, you only need weighing scales. For muscle structure and for muscle mass assessment, you need more sophisticated imaging techniques like DEXA scanning, bioimpedance analysis, or MRI scanning. And in this case, there is no weight loss. In cachexia, there is weight loss. In the case of sarcopenia, there's no weight loss. So usually this is picked up much more difficult, and the diagnosis is not made very often. But this is also the case for cachexia. But patients with heart failure, they lose muscle earlier than other tissues. They lose muscle earlier than, for example, fat tissue. This is part of the problem because muscle is quality of life because it's exercise capacity. Cachexia means a poor prognosis in itself. At the time, Susanne Fürster, she was my MD student in Berlin, we looked at muscle wasting and sarcopenia in heart failure patients, and we found that almost 20% of ambulatory heart failure patients are affected by sarcopenia. And these patients have reduced muscle function and muscle strength. And we found reduced hand grip strength, reduced quadriceps strength, and we found a lower exercise capacity on the 6-minute walk test. Unfortunately, the labeling is in German here, but I think it's still understandable in a way. The peak VO2 is also significantly reduced in those patients who were sarcopenic. And like 2 years ago, we saw that also muscle wasting, sarcopenia in heart failure, is an independent predictor of poor survival in patients with heart failure as compared with patients who do not have muscle wasting, so no sarcopenia. Finally, we found also one of my MD students, Ame Imami, that sarcopenia and cachexia, they do overlap in heart failure patients. So what we found is that cachectic heart failure patients, these were 207 male patients of heart failure, and we found that 1/3 of patients had any form of wasting. So sarcopenic heart failure in 30 patients, cachectic heart failure in 25 patients, but 14 patients who were not identical with one or the other, they fulfilled both criteria. They fulfilled the criteria of sarcopenia and cachexia. And we kind of only used these, well, makeshift terms, sarcopenic heart failure, but they were used in another publication that I will show you in a second later on. But the interesting thing is that only those patients with sarcopenic heart failure, or what we called sarcopenic cachexia, they were the patients who have reduced quadriceps, hand grip strength, reduced 6-minute walk, and reduced peak VO2. So the important thing is really to understand that those patients who lose muscle, they also lose quality of life. And as mentioned, published in 2019, the terms sarcopenic obesity, sarcopenic cachexia, they appeared in another publication already. And you can see that fat mass, bone mass, they all might be affected in heart failure patients depending on what type of wasting is present in the respective patients. This is the European guidelines for heart failure, and this is the paragraph about frailty, cachexia, and sarcopenia. In essence, it says that cachexia and sarcopenia are very prevalent in heart failure patients, and that there might be some ideas what we can do about it. But the one thing that these patients really need is exercise training and maybe some additional protein intake. But for the most, we do not really know how to treat wasting in patients with heart failure. Can we treat muscle wasting? The answer is maybe, but we do not have good trial data. So what we looked at, and the chairperson of the heart failure working group in the German Cardiac Society, and with that society, we looked at therapies to improve exercise in heart failure patients. And we did a systematic review, and we found only ivabradine, exercise training itself, and the treatment of iron deficiency to be effective at improving exercise capacity. Now, ivabradine is a substance that reduces the heart rate. But all the other standard therapies for heart failure that I mentioned before, ACE inhibitors, beta blockers, MRAs, ARNI, SGLT2 inhibitors, they do not improve exercise capacity. But the treatment of iron deficiency does, and this is something I would also like to highlight briefly, and the treatment of atrial fibrillation does if there is pulmonary vein isolation, an ablation method. But let me give you a very, very brief overview of what iron can do in the muscle, because we do see that up to 50% of heart failure patients have iron deficiency. Now, in each muscle, the mitochondria, they are part of oxidative phosphorylation, and CK, creatine, is the shuttle for phosphocreatine. And that is used for contraction purposes, as the ATP and the phosphate for ATP generation is produced in mitochondria in the respiratory chain. So iron now is part of all the enzymes in the respiratory chain. And there is an elegant study by Charles Edwards from Obi Okonko's group in London, and they used phosphocreatine MRI, magnetic resonance imaging, to visualize the effect of iron inside the muscle. So what they did is they administered iron to patients with iron deficiency and heart failure, and they saw that the phosphocreatine recovery in skeletal muscle was much faster when patients were randomized to iron treatment as compared to placebo. So you can see here that in this case, iron isomaltoside, it reduced the phosphocreatine half-time. So the recovery of phosphocreatine was reduced and was much quicker than in the placebo group. So with iron, we can provide, in patients with iron deficiency, we can provide an energy substrate that helps regenerating the muscles' exercise capacity much quicker. I think this is an interesting approach that might be worthwhile to consider. And you can also see here that iron withdrawal in human cardiomyocytes using deferoxamine, it leads to the relative ATP level being reduced to -74%, but the addition of iron leads to a renewal of the normal situation very quick. So this is an interesting approach, I believe, with which we can help patients who do have iron deficiency. Now, Iron Man is a study that is still ongoing, and if you think about it, Iron Man is actually female. Finally, what about other cardiovascular illnesses? We do have some data on other cardiovascular illnesses. And together with Agata Bieleka-Dabrova, she visited my team and me in Göttingen. And we did an analysis of other arrhythmias, of other cardiovascular illnesses, including arrhythmia, peripheral artery disease, coronary artery disease, cardiac surgery, valve implantation. And we tried to understand, is there an interaction between frailty, sarcopenia, and cachexia in selected cardiovascular disease? And I'm only showing you here the influence of cachexia to develop the illness. And for example, we saw that if patients are cachectic, then there is a higher risk to develop heart failure. If patients are cachectic, based, for example, on cancer, there's an increased risk to develop atrial fibrillation. And the influence of cachexia on the course of the illness. So, for example, if patients have heart failure and are cachectic, then cachexia is an independent predictor of death and a poor prognosis. And we do have some similar data, for example, for coronary artery disease, or for patients after a TAVI implantation, which is an aortic valve implantation. So patients who did receive an aortic valve implantation and are cachectic, they have a higher mortality rate. But this is something we do not have a lot of data, as you can see from the no data points that are really shown in most of the table here. All this data is summarized in the paper that was published 2 years ago, and we have also tried to summarize this in a graphical abstract. But this is also kind of busy, and you need to think about it for a second. For example, in blue, you see the influence of sarcopenia on the prevalence of heart failure, which is increased. And on the other end of the arrow, you can see that morbidity and mortality are increased in heart failure patients the moment sarcopenia is present. We have tried to summarize all the data that we found in this graphical abstract, but as I mentioned, all this is kind of busy, and you also see that many arrows are missing here because we simply could not find any data. For example, we could not find any data on cachexia and coronary artery disease. We could not find any data on the prevalence of sarcopenia, frailty, cachexia in patients after TAVI implantation, and so on. So the clinical consequences of muscle wasting is present in many cachectic patients, but it's a genuine clinical entity in patients with heart failure and other cardiovascular illnesses. There's an increased risk of falls and fractures, which leads to frailty. There's an increased risk of hospitalizations, and finally, reduced physical activity, fatigue, and weakness. They worsen the muscle wasting itself. And I'm coming to my last slide, that the disability increased medication, increased mobility, increased length of hospital stay. They all lead to increased in-hospital and healthcare costs, and we need to find patients early so that we have a chance to really start and try at least to treat the muscle wasting and the sarcopenia. And if not only, what we can do is we can ask patients to exercise more. And I'm really happy to say if my patients are only walking their dogs or walking and taking a brisk walk, then this is something that their muscle will really benefit on. So thank you very much for your attention, and I'm looking forward to the discussion.
Thank you very much, Stefan, for that very informative talk. So we have time now for some questions. So if anybody wants to raise their hand, and I will unmute them, or alternatively, we can use the Q&A. So anybody at all? We have a question here from Deepak. Apologies if I haven't pronounced your name correctly. Do you want to off you go?
Yeah, that's correct. You spelled it. So my question is, what are the diagnostic criteria for cachexia and sarcopenia?
Well, the diagnostic criteria for cachexia is usually a weight loss of more than 5% of the body weight. And I think this is something you really have to think about it for a second, because many of my patients, they weigh 100 kilograms. And that means if someone with 100 kilograms loses, for example, 5 kilograms or 10 kilograms, that patient is still overweight, but is already cachectic, because weight loss is part of a wasting syndrome and heart failure. For sarcopenia, this is more difficult because we use appendicular skeletal muscle mass, and that means losing muscle in the limbs, mostly in the legs, and you can use DEXA scanning for that. And the definition is 2 standard deviations below the mean of a normal healthy population. And that is really something that is not easy to understand, because you really have to better understand these diagnostic criteria in the DEXA scanning. And DEXA was not developed to measure muscle mass, but rather to do osteoporosis scans. So what I usually do is I ask patients to stand up from a sitting position when they sit in front of me in the office. Can you stand up without using your hands, without holding the armrest? And if they can manage, this is a sign that probably their muscle is okay. If they cannot do it, then I will send them for a DEXA scan.
So the next part here is, so from the historical weight that a patient would have, so would you put a deadline for 3 months or 6 months that he has lost around 5% of the body weight?
I think, well, what I'm doing is I'm asking the patient, what did you weigh like 6 or 12 months ago? Then I just compare this with the actual weight at the time when I see the patient. And if there is weight loss, then and if this exceeds, well, we know that for heart failure, 6% does have a better prognostic value than 5%. But the Cachexia Society, they use the definition of 5%. But there's still a lot of debate going on about which percentage value might be the best. But I'm asking, what was your weight like 12 or 6 months ago? And then I'm comparing this with the actual weight.
Thanks very much, Stefan. I think you have time for one quick more that I'll quiz your brain. Bone loss with heart failure patients. Does it happen, and does it add to any prognosis regarding earlier death?
Bone loss was the question?
Yeah, bone loss. A lot of attendees here are interested in both bone and muscle, so I thought I'd quiz you with that one. Bone loss in heart failure patients.
We do have some data. There's not a lot of data there, but we have done an analysis, And it is actually true that also bone mineral density is lost over the course of heart failure. But it seems to be associated with other tissues that are lost. So someone who loses muscle, someone who loses already fat tissue has also a very increased likelihood of losing bone mineral density. So yes, it does.
Fantastic, thanks. Okay, so our next speaker and first of the EMCR group is Dr. ANZSSFR, who is head of the Bone and Muscle Research Group at the School of Clinical Sciences at Monash University. Dr. Zengen has held a esteemed research position at the Garvan Institute as well as Cambridge University, where she worked on the Gambia musculoskeletal aging study of aging men and women that was funded by the MRC. And today, Dr. Zengen will speak on the interaction between cardiovascular and musculoskeletal health in ethnic populations. So over to you, Aise.
Thank you. You can see my screen, right?
Yes, perfect. Thanks.
Great. Thanks for that kind introduction, Ben. Let's get started. So the prevalence of non-communicable diseases of aging are rising globally and account for 70% of deaths annually. And 80% of these occur in low and middle income countries. The highest burden is among countries in sub-Saharan Africa, mainly due to a rapid demographic transition characterized by increasing urbanization and changing lifestyle factors. So if we take a look at the image here on the screen, we have the continent of Africa, where the first image is from 1950, and we can see that there is a greater amount of darker blue sections over time, indicating an increase in urbanization by the last image depicting urbanization in 2010. Now, with this transition, there's an increase in the prevalence of obesity, sarcopenia, and cardiovascular disease, consequently giving rise to multimorbidity. Declines in physical function have been associated with multimorbidity, with more severe consequences reported in low and middle income countries, coupled to a higher economic healthcare burden. Variation in cardiovascular health potentially has a causal role in the heterogeneity of age-related declines in physical function. The Whitehall 2 study in adults aged 55 to 78 years, residing in London in the UK, reported that arterial stiffness was strongly associated with poorer physical function. More recently, data in adults aged 20 to 100 years from Berlin, Germany, show that for every 5 kilogram decrease in hand grip strength, arterial stiffness, which was measured by pulse wave velocity in this study, increased by 0.3 meters per second. Data from the US show that individuals who have peripheral vascular calcification have impaired walking ability and insufficient physical activity levels. Now, these findings contrast with the weak or absent links of blood pressure alone with physical function assessments, suggesting that a more comprehensive cardiovascular health assessment would be far more useful. Now, these 3 studies did not find sex differences in these associations, although out of the 3, only the study in Berlin briefly said that although they showed that the association between pulse wave velocity and hand grip strength existed in both sexes, it was much less pronounced in women than in men. There's also recent data that show ethnic differences in some cardiovascular risk factors. For instance, lower HDL levels in sub-Saharan African populations is part of a pattern of lower overall cholesterol. And so isolated low HDL levels in sub-Saharan Africans wouldn't accurately predict cardiovascular risk. And finally, there's sex differences in body composition, which may affect the associations between cardiovascular health and physical function. Currently, there's no data on this. And so the aims of this study were to investigate the sex differences in cardiovascular disease risk factors and poor physical function, and whether this relationship is mediated by body composition. So let me give you a very brief background about the study context, as many people aren't very familiar with the Gambia. Participants were from the Gambian Bone and Muscle Aging Study, or GAMBAS, which is a longitudinal prospective observational study. But the data that I'll be presenting today are from the cross-sectional analysis of the baseline study visit. So briefly, men and women aged 40 years and above were recruited from the rural region of West Kiang, shown here on the map on the slide, which is the red region of the Gambia. And those who were pregnant, lactating, and deemed physically too frail were excluded from the study. In terms of cardiac parameters, we calculated rate pressure product by multiplying heart rate by systolic blood pressure. Rate pressure product is an indication of cardiac workload, where a higher rate pressure product corresponds to a higher cardiac workload. And it's also been associated with myocardial oxygen consumption. Pulse pressure was calculated as systolic minus diastolic blood pressure and is a measure of arterial stiffness and an independent marker of cardiovascular risk in adults aged over 50 years, particularly myocardial infarction and coronary heart disease. And finally, peripheral vascular calcification was assessed from PQCT scans taken from the tibia and has been associated with peripheral artery disease in the legs, leading to impaired blood flow and oxygen delivery to the lower extremities. Body composition was measured from a whole body DEXA scan, where we measured whole body lean mass and whole body fat mass. Appendicular mass, lean mass was also calculated, and this was corrected for body height, yielding appendicular lean mass index, or ALMI, and we did the similar calculation for fat mass, so fat mass index, or FMI. Now turning to the physical function parameters, participants were asked to perform 2 tests on a ground reaction force platform, a chair rise test where we measured power, and a single 2-leg jump where we measured force and power. We also measured hand grip strength using a hand dynamometer. So let's first take a look at the participant characteristics. In total, 239 men and 249 women were recruited. Now, just to put it into context, in the Western world, these numbers don't necessarily seem that large for a population study, but if you think about the study context, this is actually remarkably large. In fact, this is the largest musculoskeletal study in sub-Saharan Africa. And given the array of measurements that I just mentioned, having these located in such a rural region is quite amazing. So women weighed less and they were shorter. With regards to body composition, women had higher fat content and fat mass index compared with men. And in contrast, men had higher lean mass, ALM and ALMI. In terms of mean values of cardiac parameters, women had higher heart rate and rate pressure product. And finally, in general, men had better physical function when compared with women. Now turning to the association analyses that we performed. So these graphs show the associations between rate pressure product, which is on the x-axis, and the various physical function parameters on the y-axis, which you can see. We have chair rise test power, force and power from the jump, and the hand grip strength. We have the men in blue and we have the women in red. So following adjustments for age and fat mass index, every 10% increase in rate pressure product was negatively associated with single 2-leg jump force and power in men, but not in women. And in line with this, there were also sex differences in the associations between pulse pressure, so the marker of arterial stiffness, and physical function in men and not in women. And the graphs display this quite clearly. So we can see a significant negative association in men and not in women in all of the various physical function parameters. The presence of peripheral vascular calcification in men was negatively associated with single 2-leg jump power and hand grip strength only after adjustments for age and ALMI shown by the blue box on the screen. In addition to these associations, following adjustments for age and fat mass index, there were greater negative associations in men with chair rise test power, single two-leg jump force when compared with women. You can see in the green box on the screen. So next, we wanted to see the role of body composition in these associations, if there were any. And so we performed mediation analysis. In men, this analysis revealed the negative associations between rate pressure product and physical function parameters were mediated through fat mass index, which you can see in this schematic on the slide. Although the mediation effect was rather small, you can see the data on the screen, it was actually statistically significant. There was no mediation effect of appendicular lean mass index on these associations. Fat mass index and appendicular lean mass index did not significantly mediate effects on pulse pressure or peripheral vascular calcification and physical function parameters. And finally, there was no mediation of appendicular lean mass index or fat mass index in women. So in this study, we report sex differences in the associations between cardiovascular risk factors with physical function in a rural population of Gambian men and women. Rate pressure product, pulse pressure, and peripheral vascular calcification were all negatively associated with physical function in men, while there were no associations in women. And these effects in men appeared to be mediated via fat mass index and not appendicular lean mass index. So there's a couple of ideas as to why this is happening in men and not in women. Well, it may be partly explained by the smaller variability in body composition in this rural population of Gambian men compared to the women. And we've previously shown that with increasing age, there's a greater magnitude of variation in body composition in women than in men. And some of the factors that could be contributing to the variation, the high variation in lifestyle or even life events in Gambian women could be parity, sex hormones, and other factors such as diet, physical activity, and living arrangements. And so with that, I'd like to acknowledge the various people who were involved in this work, primarily the MRC unit in the Gambia, SAMSON, the London School of Tropical Hygiene and Medicine, and where this whole project is led by Professor Kate Ward, and also my team at Monash University. Thank you.
Thank you for that amazing talk, Aisha. Some really interesting findings and explanations as well. So I'm just waiting to see if we have any questions. So the raise hand function, just for all the attendees to remember, or the Q&A, if there's anything there. Nothing so far, I say. So, oh, wait, Mark has one. Mark, do you want to fire away?
Hi, Aisha, thank you for that really nice talk. In a lot of your physical function measures, you were actually using somewhat more complex functional measures. I guess with actually using measures of power. Is that where you think we're going to find the biggest differences, not necessarily strength or, like, say, the timed up and go, which really is a combination of strength and movement, where force or power generated over time is where we really should be looking at in terms of disability and I guess negative health outcomes?
Yeah, you make a good point, Mark. And like you said, this is more complex, and it's not going to be in the doctor's clinics when they see the patients in the office. But I should just a disclaimer, these are secondary outcomes. They weren't the primary outcome of the actual study. And so firstly, we were limited with the physical function parameters that we actually did perform at the baseline measurement. And so unfortunately, we didn't have timed up and go or gait speed or, those ones that you mentioned. So that would actually be nice to actually see which ones are better at predicting these things. So sadly, we can't do that in my study, but it would be great to see it in other cohorts that have all these measurements in order to be able to definitively answer your question.
I guess it's also very interesting that you present the appendicular lean mass values in the index, and it quite clearly, in my opinion, shows that you can't just apply one standard from one population across different populations and assume that the prevalence will be the same. Like those prevalence numbers are going to be completely different if you use a Caucasian population values and apply those sarcopenia definitions to these ethnic populations as well. So thank you.
I say there's none more from the attendees, so I'll ask a very quick one before we move on. Probably a challenging one to answer, but what do you think comes first? A decline with cardiovascular health or musculoskeletal with aging, or is it bidirectional or chicken and egg scenario? What's your thoughts?
Yeah, literally, that's what I was going to say. It's the chicken and egg scenario. To be honest, I can't answer that question. Like you said, that's a tough one, but I personally just think that measuring the cardiovascular outcomes, I think that happens first before the physical function declines, but I can't support that by any kind of data at the moment. So yeah, that's just my impression, because I feel like those sorts of things, they're a bit more, they happen more rapidly, whereas I think declines in physical function, they take a bit more time to happen. So yeah, that's just my my personal opinion.
That's what I wanted, your own opinion. Okay, thanks so much, I say. And that closes the first half of the webinar. So I'd like to hand you over to the lovely Julie McDonough.
Thanks, Ben. I'm Julie, as Ben said. I'm on the EMCR committee of the ANZSSFR, and I'm also on the Cardiovascular Nursing Council of the Cardiac Society of ANZ. So I'm thrilled to be here and that we could bring together such a great program for you all. And I'm delighted to present our next speaker, Associate Professor Caleb Ferguson. He is a Principal Research Fellow and Associate Head of Research at the University of Wollongong, New South Wales, Australia. Associate Professor Ferguson is an NHMRC Emerging Leadership Fellow and leads a program of clinical research in stroke prevention, cardiovascular disease, frailty science, and digital health. Thank you, Caleb.
Great, thanks so much, Julie, for that introduction, and also thank you for the organising committee for the invitation to share with you today some of the work that we've been doing in Western Sydney in relation to clinical frailty in the acute care setting, particularly in the aged care setting, and a couple of the metropolitan hospitals in Western Sydney. My talk might be slightly different. This is an ongoing study that is a 5-year study, and we're only around about sort of 2 years into this, and we've obviously had the pandemic to deal with as well, but it'd be good to share with you some of the project design and some of the initial findings from our registry as well. I wanted to start off by also acknowledging the team that we have. I co-lead the Western Sydney Clinical Frailty Registry with Professor Richard Lindley, and we have a large multidisciplinary team based at Blacktown and Mount Druitt hospitals. And one of the objectives of our study in relation to clinical frailty is around capacity building in frailty science with nurses, allied health and medicine as well. And this project is providing a lot of capacity development in relation to frailty research at Blacktown and Mount Druitt. The project is funded through a bequest by the late Frank Harvey, and we've also registered this clinical registry with the Australian Register of Clinical Registries, which is a bank of clinical registries in Australia as well. And the idea for this clinical registry, I have previously worked with Julie at St Vincent's, and we were involved in a study called the Heart Failure Snapshot, which was a large observational study looking at frailty and heart failure as well. And we wanted to look at sort of replicating something similar like the snapshot, but looking at a longitudinal approach in aged care in Western Sydney as well. So a lot of this has been covered already, and I won't spend long on this, just to say really that frailty is an increasing a condition in relation to increasing attention linked to multimorbidity in an aging population. And it's become not only a local priority in Western Sydney, but a global health priority as well. But the rates of frailty are somewhat vague in terms of how individuals are impacted who are community dwelling, but the consequences of frailty are well established in relation to worsening health outcomes, disability, hospitalisation, mortality, and obviously increased healthcare utilisation and cost as well. We're quite interested in clinical research and clinical trials in Western Sydney, and we recognise that sometimes frail, very elderly or older adults are often excluded from randomised controlled trials, and therefore this is a major cause for concern, and we're really interested in recruiting more frail older adults into our clinical trials that we run in Western Sydney. But new approaches are really needed to address frailty and dementia identification, treatment and management as well. So as I've previously mentioned, the objectives of the Western Sydney Clinical Frailty Registry, first of all, was really to obtain a representative cross-sectional view of patients that were admitted under the Rehab and Aged Care Service in Western Sydney Local Health District. And this is one of the busiest, I would say, health districts in New South Wales. And we wanted to establish this clinical profile of the patients that were admitted to rehab and aged care services, and really to describe the rates and the outcomes for patients with frailty admitted across the service as well. A secondary objective was really around this capacity building, multidisciplinary research capacity building in frailty science in Western Sydney as well. So this is a 5-year prospective cohort study, and we've also built in some capacity to do data linkage studies. In designing the study, we wanted this to be very light touch and really low burden on clinical care and on clinicians collecting the data. And I'll talk a little bit about that in a sec as well. We used quite a number of measures, but the Rockwood Clinical Frailty Scale, but also the FIED, which is created from the Inter-RI-ED tool, and it's 24 variables. We've also got the Karnofsky Performance Scale as well. And we followed up patients at 3, 6 and 12 months after their discharge from hospital. We have a model of consent whereby we can also do proxy consent, and this is particularly useful for patients, participants with dementia, and making sure that we minimise bias and recruit them into the registry as well. We use REDCap to manage our data, and we've just recently moved to a fully digital data collection as well. So as mentioned, a lot of you will be familiar with the Rockwood Clinical Frailty Scale. We measured this, and this is pre-hospital frailty status, and so our mean was 5, so mildly frail individuals that are being admitted under the service. And we also, as I mentioned, use the Karnofsky Performance Scale as well. So I won't share too many results because obviously the study is ongoing, but there's a few things that I really wanted to highlight. And I guess, the average age of our participants in the registry is 81. More women, which is not really surprising, given sort of men dying earlier than women. So 39% were men. Comorbidities in relation to cardiovascular disease and stroke. I'm very interested in stroke and atrial fibrillation in particular. So, about a fifth of patients having stroke and a quarter having AF as well. And we're quite interested in polypharmacy, so quite a high medication burden with an average of 10 medications on discharge as well. But a high mortality rate at 3 months, with 12% of patients dying within 3 months after being discharged from hospital. Some of this is quite interesting to me. I'm quite interested in terms of polypharmacy, and we're quite interested in relation to some of the cardiovascular medicines that are used within this cohort in particular. And for myself, I'm quite interested in the anticoagulation status of these individuals. So still quite a high use of warfarin at 7%. Other things of interest are, I think, statin use as well, which is still 57%. And quite a high use of analgesics as well at 71% as well. One of our advanced trainees is quite interested in driving, and these are some data in relation to his sub-project and looking at driving. And you can see here that 40% of individuals in the registry had a driving license, and 62% of those had driven in the last month, and 50% of that 40% were confident in driving in the next month as well. We're also quite interested in where these patients go to and where they discharged home. So only 62% of those patients were discharged home, and quite a high use of residential aged care and transfer to other institutions as well. So to summarise, and I guess some of the strengths and limitations of our study as well, it's quite interesting when we ask clinicians about how much they know about their patient cohort, and there isn't really great data to describe the clinical profile of patients that are admitted to rehab and aged care and clinical services often. So this has really enabled us to have some quite rich data prospectively collected, and it's really helpful for us as clinicians to guide our practice and care and improve the quality of care that's provided to these patients. I guess one of the key limitations is really this opt-in model of consent, which we tried to negotiate with our ethics, but we weren't successful there, and that does create the potential for selection bias. However, we've tried a new way of recruitment and screening, and so we're trying to minimise the bias in that recruitment as well. We're describing our clinical frailty registry as a trunk sort of project for our capacity development, and this analogy goes further to say that we're having twig, branch and nest projects attached to the trunk, which is really a conduit for capacity building in frailty science. And so if we have honours students, PhD students and advanced trainees, for example, and we have a vehicle for them to easily build in a project to undertake for the duration of their study as well, and help building capacity in frailty science in Western Sydney as well. So probably I'll finish up there, and I'm happy to take any questions as well. Thank you so much again for the invitation to come along today and listen to some fantastic presentations. Thank you.
Thanks very much, Caleb, and wanted to throw it over to anybody if anyone has any questions for Caleb. No? Any questions from anybody online? I'll ask you a question, Caleb. So how have you found when you've had someone working on the study, a nurse that's taking the frailty, and so how will this, do you think that this is something that can continue after the registry study's finished, that it would be able to be easily implemented into continue the frequent frailty monitoring on participants or on patients, I guess, in the clinical setting?
That's a good question, Julie, and I think once the study finishes and the funding for our trials nurse ends, is this something that's easily implementable in routine clinical care? We've had quite a lot of success in embedding frailty assessment into clinical practice, and one of the key achievements in Western Sydney is to build in the clinical frailty scale into our electronic health records. So that's actually built into our Cerner power chart system, and we're able to do a clinical frailty scale and record that in there. But I guess there's quite wide variability in people's understanding of what frailty is and how to accurately assess it as well. And so I think there's a large bit of work to do around that as well.
Did you have a question, Mark?
Just wanted, I may have missed this, but I just wanted to ask, in terms of the registry, and correct me if my understanding of this is right, but it's wrong. but it's mainly the Western Sydney population that will be captured by this registry. Am I correct in saying that first?
Yeah, that's correct. Yeah.
And how is there how representative are the population in Western Sydney of the? Is it skewed towards a specific ethnic group? And is there any plans to roll this out into other areas? I guess.
Great questions, Mark. I think Western Sydney's probably it's a really diverse population in Western Sydney. Huge amount of immigration and a hugely diverse population. There's mixed pockets in relation to socioeconomic status and ethnicity, and so I guess the question in terms of expansion of the registry is something for us to consider, and it's definitely a wish. I think with registry data, there's been quite a lot written around the usefulness of it, and you know, are you just collecting data for the sake of collecting data and describing a cohort, and is it worth investing in? So we're the next phase of the registry, we're quite interested in developing what we're calling a Frailty learning health system, which enables us to use implementation science methods, have real-time data fed back and really applied almost real time into clinical care. So working with clinicians to really look at some of the data, see what's a priority area, and make changes and improve the quality of care that's provided.
Thank you.
Thank you.
Okay, I think unless there's no other questions, I think we'll move on to our final speaker for this evening. So our last speaker is Associate Professor Joshua Lewis. Associate Professor Lewis is a cardiometabolic health in ECU's Nutrition and Health Innovation Research Service. He leads the Disorders of Mineralisation Research Group within the School of Medical and Health Sciences. His National Heart Foundation Future Leader Fellowship focuses on better understanding of vascular calcification and how we can use this knowledge to prevent people going on to having clinical cardiovascular events, such as heart attacks and strokes. Thank you very much, Professor Lewis.
Okay, I'd firstly like to thank the organising committee for inviting me to present on such an interesting topic, and we've had some fantastic talks earlier. And I'm particularly excited about presenting on abdominal aortic calcification because it's always my favourite topic to present on. So I have no disclosures to declare. And so firstly, happy Heart Week, everyone. It's a great initiative, and yep, it's a perfect time for me to give my talk. So today I'm going to be talking about abdominal aortic calcification, or AAC, what it is and why it's important. That's the first part of my talk. And then the second part of my talk is really going to be talking about abdominal aortic calcification from bone density or DEXA, lateral spine images, and tell you a little bit about why the images are taken and how do we assess aortic calcification and what we're currently doing to automate the process at the moment. And the final part of my talk will be talking about the links between abdominal aortic calcification from these bone density machines with muscle, bones, falls and fractures in the Perth longitudinal study of ageing women. So as we know, around 4 million Australians self-report with living with cardiovascular disease, and around 19 million Australians are at risk of developing cardiovascular disease. And so consequently, 2 Australians are hospitalised every minute for cardiovascular disease in Australia, and it costs over $5 billion per year in hospital costs. And the statistic that most people know and quote is that an Australian dies every 12 minutes of cardiovascular disease. And this is predominantly from heart attacks and strokes. And it's estimated by the World Health Organization that around 40% of these deaths are people under the age of 70 years, and so preventable cardiovascular events. And so that means that an Australian is dying every 38 minutes of a heart attack or stroke, which is preventable. And so there are a huge number of initiatives to try and reduce the burden of disease. And so we have things like Heart Week. We also have better diagnostics, biomarkers,
patient clinician shared decision making, genetic risk scores, and things like structural vascular disease. And today what I'm going to be talking about is assessing structural vascular disease, in particular vascular calcification. So I get asked what is abdominal aortic calcification a lot. And my first experience with abdominal aortic calcification was in around 2009 in my first postdoctoral position, where I was looking at lateral spine images for vertebral fracture assessment. And I saw this funny tube-like structure that you see here. So we've got the spine, and then running parallel to the spine is this tube-like structure. And so a healthy aorta is soft tissue and shouldn't be visible. And so all of the white that you see in the vascular wall there is abdominal aortic calcification. And I took that to the endocrinologist in charge of the project, and he said, oh yeah, we see this all the time, but we don't actually know what it means. And so we don't really do much about it. And so that really got me on my research journey. And whenever I present on abdominal aortic calcification, I always like to point out that it's incredibly under-researched. So what we have here is a PubMed search, and you can see, you know, there's around 8,000 papers every year on atherosclerosis, around 1,000 on coronary artery calcification, but we generally have between 100 and 150 papers a year currently on abdominal aortic calcification. And a lot of these papers are small studies where the aortic calcification has been picked up, and they're linking it to certain conditions. And they may be in, say, a renal disease population, or a cardiovascular disease population, or an osteoporosis, or a sarcopenia or frailty population, but we don't have the big picture yet. So the abdominal aorta is the major artery supplying blood to the lumbar spine, the abdominal organs, the pelvis and lower limbs. And so it's obviously very incredibly important for your muscles and also your bones. And luckily, it's very easy to image. And so if we take the lateral spine image, there's no skeletal structures in the way. And so consequently, we can actually use fairly low radiation techniques to image the abdominal aorta. And so this was, this is an example here of abdominal aortic calcification using a bone density machine. And then the same individual, it's using a standard radiograph, which is considered the gold standard for looking at abdominal aortic calcification. And then this is a aortic calcification by CT, which is the most sensitive method. And so there was a really nice study done in 2016 of 308 women, whereby they looked at all of these three methodologies to see how sensitive they were. And you can see that the CT is the most sensitive, the X-ray, and then the bone density machine, lateral spine images. But overall, they're fairly similar. Another thing that we do know about aortic calcification is it's incredibly common, and it starts very early in life. And so for this graph here that I put together, it's from two studies. The first one is the P-Day study, which was done in the US, and there was an autopsy study of external causes of death. And so they looked at atherosclerosis and vascular calcification in younger people. And what you can see here in this study is that around 12 to 15% of men and women have evidence of abdominal aortic calcification in their 30s, in their early 30s. And then the second study I've taken data from is the Framingham study, which most people should know. It's one of the largest and longest studies that has been going on looking at cardiovascular disease. And so this was done using X-rays to look at aortic calcification. And you see that in the 40s to 50s, around 20 to 30% of people have any abdominal aortic calcification, and it rapidly progresses. And so the prevalence by the time you're in the 70s is 70 to 80%. And these findings have been replicated in many studies looking at CT radiographs and also the bone density machines. And I've just pointed out here in this autopsy study in that thoracic aortic calcification is a lot less prevalent, and so is coronary artery calcification in these younger individuals. And it's similarly when they've got imaging studies looking at coronary artery calcification and abdominal aortic calcification, the prevalence is usually much higher, which suggests that it's one of the first sites where you see vascular calcification occurring. Another important point when considering abdominal aortic calcification is, unlike coronary artery calcification, where they think the drivers are predominantly those atherosclerotic drivers, so your lipids and your blood pressure, it appears that aortic calcification is driven to a lesser extent by those atherosclerosis factors. And so there are a number of well-known non-traditional cardiovascular risk factors that actually drive abdominal aortic calcification. And so we know the renal disease, diabetes, interestingly, the rapid bone loss and also low muscle mass have been shown to be drivers of rapid progression of aortic calcification too. And even when you actually look at the aortic calcification here, so this is a patient with end-stage renal disease, and you see this very nice calcification that seems to be restricted clearly within the aortic wall, and this is what we suspect is medial calcifications and what we call a train track calcifications. Whereas if you see the predominantly atherosclerotic aortic calcifications, the aorta itself looks very lumpy and tortuous as well. And even within the different aortic calcification we see a whole range of different types of aortic calcification. We see very small sesame seed-like calcifications at times. We see like a ground glass calcification. And so we really don't know what a lot of these different types of calcifications reflect. But what we do know is that abdominal calcification is strongly linked to both vascular calcification in other sites as well as atherosclerosis. And so this was a study we did in 2016 where we looked at abdominal aortic calcification using the bone density machines, and we grouped it into the established cardiovascular risk groupings, which is low, moderate, and severe. And we showed that in the people with moderate and severe aortic calcification, even after adjusting for all of your traditional cardiovascular risk factors, the people with the moderate aortic calcification were 2 times more likely to have the moderate carotid stenosis, which is more than 25%. And if you had that severe aortic calcification, then you're about 5 times more likely to have that carotid stenosis. And John Shubo showed something very similar with the coronary artery calcification, whereby if you have that moderate and severe aortic calcification, you're around 2.5 to 6.5 times more likely to have that very high coronary artery calcification, which is associated with an increased risk of cardiovascular events. And there have been 2 studies where they've looked at aortic calcification as an independent predictor of coronary artery calcification progression and also development. And both of them have shown that aortic calcification adds to the existing atherosclerosis risk factors as an independent predictor, and it's the strongest predictor in one of those papers as well for the progression of coronary artery calcification. So that really reflects it's probably one of the first sites where it occurs, and it's very important for driving atherosclerosis and calcification at other sites. But what we really wanted to know was, what is the fundamental prognosis that you see in people if they have aortic calcification? So that's really to address the clinical question of, if my patient has aortic calcification, what's going to happen to them in the future? And so to do this, we did a systematic review and meta-analysis, and we looked at any prospective study that reported aortic calcification by any imaging modality in any clinical population, and looked at the future risk of cardiovascular events, fatal cardiovascular events, all-cause mortality, stroke, and coronary heart disease. And the way that we had to do it was we had to use the lowest reported aortic calcification group, because there was a number of cut points used. And so some people used, did they have aortic calcification or not? Other people used the low, moderate, and high, the established cut points. So we used the lowest group as the referent, and then we combined all of the other groups, so the moderate and the severe, if they had 3 groups, or just the presence. And then we compared those using a pooled relative risk. And importantly, we explored clinical, methodological, and statistical sources of between study heterogeneity. So we wanted to understand what are the factors in these studies that are affecting the prognosis. And the first thing that was clearly evident was that in the chronic kidney disease population, there was clinical heterogeneity compared to the general population. So what that actually meant here is these are the results. And you can see here that we had a fair number of studies. So in the general population, we had 4 to 6 studies of between 8,000 and 9,000 people. And in the chronic kidney disease population, we had 4 to 9 studies and between 1,000 and 2,000 people. As you can see, the blue arrows represent the general population versus the red arrows in the chronic kidney disease population. And so if you had aortic calcification and you had chronic kidney disease, your prognosis was substantially worse than if you had it in the general population. And so in the general population, if you had any or more advanced aortic calcification, you're roughly twice as likely to have a cardiovascular event, fatal cardiovascular event, or die in that study. However, if you had aortic calcification and chronic kidney disease, you were 2.5 to 3.5 times more likely to have those events. There wasn't enough studies in the chronic kidney disease to look at stroke and coronary heart disease alone. And importantly for the clinicians, the absolute risk differences seen between the low versus the any was very large. So around 13 to 17% for the chronic kidney disease population and around 9 to 17% for the general population. And interestingly, there was a missing mortality component in the general population, which was that in the chronic kidney disease, the increase in all-cause mortality seemed to be driven almost exclusively by fatal cardiovascular events. But in the general population, the increase in all-cause mortality was only half explained by those fatal cardiovascular events. So other reasons people are dying with aortic calcification. And so that kind of ties into my last bit of the talk, which we'll touch on after we do the middle bit. So also important to note was that when we looked at the studies that reported 3 or more groups, we also saw that with increasing calcification, there was increasing risk. So it does seem to be a typical dose response. So the key points from this part of the talk are that AAC is common and captures new non-traditional cardiovascular risk information. It's a marker of the presence and progression of asymptomatic cardiovascular disease at other vascular beds, and it really identifies people with a higher cardiovascular risk and a poorer long-term prognosis. And we have a number of questions. Does providing this information to clinicians and patients help patients understand and manage their cardiovascular risk better? And so we're running a randomized controlled trial on this aspect at the moment. And we'll hopefully have answers in the next sort of year to 18 months. And the second part is, does it improve predictive performance compared to traditional risk assessment models? And really, I don't think the aortic calcification data is there yet, because we just don't have those very large studies that you need for those sort of things when you look at other risk factors like coronary artery calcification. So the second part of the talk is talking about bone density machine lateral spine images, why the images are actually taken, and how do we assess aortic calcification, and our work that we've been doing automating the process. So over 500,000 Australians get their bone density done each year, and traditionally looking at the hip and spine bone mineral density. However, the clinicians can also ask for an additional lateral spine image if they suspect that there is an asymptomatic vertebral fracture. And so what you see here on the left is a very healthy looking spine with no aortic calcification. What you see on the right here is a vertebral fracture, and this person also has abdominal aortic calcification. And increasingly, guidelines around the world are starting to look at whether or not we should be doing these lateral spine images in older people, even if they are in the osteopenic range. And that's been driven by studies like Bill Leslie's Canadian study, where they found that you only need to screen 8 women to identify one woman with a vertebral fracture, and only 4 men to identify a person with a vertebral fracture. And previous work that we've done has shown that the fracture risk in these people with these asymptomatic vertebral fractures is actually comparable to people with osteoporosis, and should be an indication and should be a fracture risk factor. So how do we actually assess aortic calcification from these images? So we use a very well-described method that was developed in the Framingham study, which is the Corpilla method, and it's a semi-quantitative method. And essentially what we do is we look at the lumbar vertebrae L1 to L4, and if there's no calcium, it obviously gets a 0. If the calcium is less than 1/3 of the height of the vertebral region, then it's given a 1. If it's more than 1/3 but less than 2/3, it's given a 2. And if it's more than 2/3, it's given a 3. And then we look at the posterior and the anterior walls. And we essentially just add up those 4 sections. And so here's an example of how we do it. And so it's more than 2/3 on both the posterior and the anterior wall. And so we would give it a 6 for this segment. And this person has a very high aortic calcification score, as you can see. The real problem is that you have to sit in a darkened room with the radiology monitor to do this, and it's very time consuming, and the image quality isn't as high as the standard x-rays, and so you really need trained readers who have a lot of experience, and there's probably only a handful of these trained readers around the world. And so we've had a consortium going for the last sort of 5 years, where we actually run training courses to try and train people in how to read aortic calcification. But our big problem is that we have tens of thousands of images, and it would take a trained reader, 80 years to actually read all of the images that we've got. So we moved on to machine learning as a way of actually clearing these backlog of images. This is the overarching goal, and I've kept it very simple for time purposes, but essentially what we want to do is we want to be able to capture these lateral spine images, plug them into a computer, and it spits out an aortic calcification 24 score. And to do this, we've used all of these images have either been read by Professor John Shubo, who developed the AAC24 for bone density machines in 2006, or people that he has trained. And he's pretty much one of the world experts in reading these images. And we used around 5,000 images and across 5 different makes and models of bone density machines. So the 2 from GE and 3 from Hologic. And they all had expert assessment as well, which is very important. And really this was a proof of concept study. We wanted to see whether or not the machine could learn like the human. So the key points is that aortic calcification can be easily captured in large numbers of people using already established infrastructure. The proof of concept data shows that machine learning can automate the AAC24 assessment process and provide clinically meaningful results. And we're really hopeful that once we can implement these steps, then from a research perspective, some of these large studies that have tens of thousands of lateral spine images can actually get AAC24 results, and the epidemiology around aortic calcification and outcomes can improve, hopefully, rapidly. So the final part of my talk is really touching on what the webinar has been talking about today. And that's, what does this aortic calcification, what are its links to muscle, bone, falls and fracture? And so I just put this slide in. It captures a lot of what has been talked about today, but there are lots and lots of links between aortic calcification and musculoskeletal health. We've also touched on the chicken or the egg component, and I'll be controversial, and I will say, given that aortic calcification starts so early in life, before the development of peak, or around the development of peak bone mass, it might be that vascular calcification precedes impairment in bone mineral density, but that's just been me being controversial. So I'm not going to talk too much about the method, about the potential links. I just want to put that in. I am going to talk about some of our results in the Perth longitudinal study of aging women. And so this study was started in 1998, and it was a 5-year randomized controlled trial of calcium supplements. And then we got 2 subsequent NHMRC grants. And it's one of the only studies that has very deep muscle, bone, and cardiovascular phenotypes. And we have more than 100 biomarkers of different muscle, bone, cardiovascular phenotypes as well. Every 2 to 3 years, they came in and they would get their grip strength timed up and go. We'd get DEXA, body composition, all those sort of measures collected. We have all their linked hospital emergency mortality records. And, you know, we also called them up every 4 to 6 months and checked whether they'd had falls and fractures. So it's a very rich data set. And so in this epidemiological study that was led by Dr. Alexander Rodriguez, he showed that in around about 1,000 of these women, that the severe aortic calcification was associated with an increased decline in grip strength. And this was the first study that had actually shown this. And this was adjusted for age and cardiovascular risk factors and other muscle factors. And interestingly, the decline was greatest in people who had a normal appendicular lean mass versus those who did had a lower appendicular lean mass. And just last year, the NHANES study, which has also got aortic calcification, showed that in men and women who had this severe aortic calcification, they had a lower grip strength by about 4 kilos for men and about 2.5 kilos by women. So really supporting the data that we brought out. This led us to ask, well, if aortic calcification is related to poorer muscle function, is it related to injurious falls? And so these are falls that result in a hospitalization, and we get this data from external cause of injury codes from the hospital record. And so we showed that roughly 7 out of 10 women had any aortic calcification, and in these women with any aortic calcification, they're at a 39% increase in the relative hazard for having a falls-related hospitalization over the next 15 years. And we adjusted for all of the usual falls risk factors. We also included grip strength, timed up and go, and bone mineral density, and it was still independent of all these factors. So aortic calcification really identifies a population that are going to have a greater decline in their grip strength and also an increase in their falls risk. Another number of studies that we've run is looking at this aortic calcification and bone mineral density and fracture. And it really makes sense because there are shared signaling pathways between the vasculature, the calcified vasculature, and the bone. And, you know, for example, the aortic calcification affects the lumbar arteries, which will then feed into, say, your spine and your vertebrae. So in this study, we looked at the Perth longitudinal study again, and in around about 1,000 women. And what we showed was that roughly 1 in 2 women has this moderate to severe aortic calcification. And this was associated with an increased risk of clinical fractures. And so these were identified every 4 to 6 months by self-report. And then we actually asked for the x-rays. And then also we had fracture hospitalizations. And so these again were hospitalizations due to a fracture over a 10-year period. And so what we showed was that there were roughly a 40 to 50% increased risk of fracture if you have this moderate to severe aortic calcification. And the aortic calcification was cross-sectionally related to bone mineral density. And once we put that into the model, it actually knocked out the fracture hospitalizations, but the clinical fractures remained significant. And that sort of suggests that the relationship between AAC and BMD may be partially explaining the fracture risk. And Dr. Alex Rodriguez has kept on this topic, and he's got a meta-analysis looking at aortic calcification, bone mineral density and fracture currently in submission. And his findings are very similar. You know, when you meta-analyze these studies, the relative risk is quite similar to what we found in the Perth study. Really supporting the findings. So the key points from this part is that AAC is a good marker of decline in muscle function, as well as modest increase in long-term injurious falls and fracture. And whilst that increase may be relatively modest, it's a large proportion of the population, an increased risk. and it's independent of what we already measure. We have lots and lots of work to do, further mechanistic studies, looking at signaling pathways, larger prospective studies and interventional studies are needed to show that if we can actually prevent vascular calcification, does it actually improve musculoskeletal and also skeletal health. And I'd just like to say we're always happy to collaborate. We have a huge data set, and I love listening to new ideas. The work that I've gone through very quickly is the work of many, and so I'm certainly need to acknowledge all of the people who've been involved, particularly the participants of the Perth longitudinal study, Richard Prince, who set it up, and John Shubo, who's done an incredible amount of work with the aortic calcification. And thank you all as the audience and the funders. And I hope you've enjoyed your whirlwind tour of aortic calcification.
Thank you so much, Joshua, for that fantastic talk. There's a question that's come through in the Q&A asking, can you explain a bit about the risk factors of aortic calcification, particularly dietary, vitamin D, calcium, magnesium?
Yeah, so there isn't a lot known about the risk factors for abdominal aortic calcification, the dietary ones. We do know that there are those atherosclerotic drivers, and so your lipids and things like that. But there is probably the best evidence is the vitamin K in the chronic kidney disease mineral bone disorders area. But we also suspect that we're going to see the same in the general population and the atherosclerotic calcifications as well, is that we will see that. The other areas that there is little bits of evidence is around fruits and vegetables, and so we've published looking at cruciferous vegetables, which are vitamin K rich, but there are also other components of those as well that we suspect may be responsible for that. And we've previously published on flavonoids and also apples, which are particularly rich in flavonoids and its relationship with aortic calcification over time. But it's really an emerging area, and once we have bigger cohorts, we can start to look at it.
Okay, great, thank you. And we have a question from Jesse, who's going to ask the question himself.
Hi, Josh. Great presentation. Very enjoyable. I'm just wondering, you've shown a lot of associations and risk profiling and prognoses. With that information that you gather, I'd be interested in your thoughts on whether this is going to be answered by your RCT as to how clinicians act on that information, particularly given, I suppose you said we've got 550,000 DEXs, and of your study cohort, 1 in 2 had moderate to severe calcification. So I think from a clinical perspective and a public health perspective, next steps would be really useful to know whether that's the outcomes can be reversible, because I suspect there'd be a huge wave of those seeking further investigation if the machine learning was run on that big cohort.
Yeah. So I suppose that's where we've been focusing our work, is really about how this information can be used by the GPs and the patients. And so there is a wealth of literature around coronary artery calcification, and more recently from the VIP-Visa study, where they showed carotid ultrasound images to their patients and also provided that to the clinicians. And what most of that literature suggests is that if you provide these vascular images, then that actually helps to activate the patients and to say, for instance, begin statin medications or to take more of their statin medications. Both the EYES and the randomized control trial and VIP-Visa showed that if you showed patients their vascular health measures, then they actually controlled their risk factors over a fairly long period of time. And so it's really going to be helping to promote those lifestyle messages, the risk factor control, and hopefully reinforce the message, the importance of cardiovascular health during aging.
Thank you very much for that, Joshua. I think I'm going to pass now to Jack, who's just going to finalise a few things before we finish up. But thank you so much for that brilliant presentation.
Thanks. Thanks, Julie, and thanks, Josh, and all the other presenters for today. I'm just going to pass over now to Professor Clara Chow, the President of the Cardiac Society of Australia and New Zealand, for some closing remarks before we close the symposium.
Thanks, Jack. Can you hear me?
Yes.
Great. I mean, I'm not going to make too long closing remarks because I realise you're over time and it's obviously at the end of the day. But look, I think this was a fantastic inaugural, I think, a collaborative forum to discuss a very important and obviously growing area of both clinical and research, I think, interest. You know, the importance of the intersection between frailty, sarcopenia and cardiovascular disease is definitely not going away, and definitely of increasing importance. And certainly some of the things presented in these presentations have given more food for thought rather than completely answered all the questions, but that's all good as well, because obviously more research needs to be done and more questions need to be answered, and probably continuing the connection between you know, people that are here in this forum and hopefully beyond this forum will enable those questions to be addressed. I'd like to flag that Cardiac Society Australia New Zealand is a 70-year-old now organisation that celebrates our 70th birthday this year. We have got our annual scientific meeting in August, and it is going to be in person and in the Gold Coast, and we're looking forward to that with excitement, as in looking forward to meeting face to face again. This meeting is our lead scientific meeting of the year, and we look forward to seeing many people attend, and hopefully people here will be able to attend as well. Cardiac Society is the chief professional body of cardiologists, as well as professionals working in the area of cardiology, including researchers, scientists, nursing and allied health, and many others. So I think I better leave it at that, because I'm sure everyone wants to go home, but congratulations and thank you for inviting me to attend.
Perfect. Thank you very much, Clara. And yeah, I'll just quickly take the opportunity again, and Andrea mentioned it at the start, but I'll just quickly plug the ANZSSFR annual meeting again, which is being held in Brisbane in person as well as virtually. Abstract submission is still open until May the 15th, so there's still time to get an abstract in, and early bird registration is still open until May 15th, so please have a look at the conference website for some more information. But otherwise, that's everything for today, so just thank you again to all the presenters for what I'm sure you'll agree was 4 excellent presentations, and thank you to the organising committee and the session chairs, and to all of you for attending. Yeah,